everyone. I guess we are just giving a few more time for people to join. Ikenna, thank you. Ikenna, do you want to stop? All right. Thank you, everybody. And a very warm welcome to everyone joining us from all around the world for this Nisa Research Week. Thank you so much for creating time out of your very busy schedule to join us. Uh, like you know, the Nisa Research Week is a 5-day program where we meet every day to touch base on implementation science and how it impacts us all, both our health systems, specific diseases, training capacity. On day one, right, we talked about advancing implementation science in health and healthcare. And yesterday, we also heard from a panel on research training and capacity building. Today, we'll be talking about implementation science for chronic diseases. And today, we have a panel of experts that will be sharing their experiences and their knowledge with us. And we are thankful to everyone that has created time both to speak to us today and to come to listen and to ask questions. We hope that today's session will be an excellent opportunity to ask questions and to create new networks. To introduce our panel of experts for today, I will introduce Uduak Akpan, who will help us introduce the panel of experts. So, Uduak, over to you, please.
Yeah, thank you very much, Dr. Olaiko, and hi, everyone. I'm really delighted to be here today, and I hope it's the same for you. So today we bring together experts who are not just advancing the science of implementation, but in their different spheres, but are also focused in chronic diseases, the topic we are discussing today. Before we do that, we did love you to go through a poll. I don't know if it has been included already on the chat box. Dr. Tonia, please confirm you've included the chat.
We're about to put it on the chat now. Thank you.
All right. So we just want to gain your perspective on the aspects we're going to be discussing today, especially implementation science when it comes to chronic diseases. So let's just take time. The link is going to be shared, which is already, okay, I think it's done. Dr. Tony has just dropped that. Okay. So please, it's really going to be nice if you do that. Just take time and go through the poll. All right, so back to our panelists. We are fortunate to have a panel of outstanding speakers, and in no particular order, I'll start from Cara Lewis. Ikenna, please, are you sharing from your end, or do I need to share the profile?
Would you like me to share the slides now? I'm happy to do so.
Yeah.
Okay.
Yeah, go ahead. Go ahead, Ashley.
Yeah.
Okay, Kara, just 1 minute.
Okay, Kara, not the presentation, please, just the profile. We want
Uduak to introduce you properly. You know, you are a guest of honor, right? So let's let Uduak introduce you properly. Yeah, thank you, Kara. Uduak, please.
Yes, I needed. Okay, I'm going to share my screen so that we have. All right. Dr. John, please confirm you can see my screen.
Yes, we can see now. Thank you. All right, go on, Uduak, who can see.
Okay, that's fine. Thank you very much. So,
hello, Uduak. Can you hear us? Uduak, can you hear? Are you here?
I don't think she can. I don't think she can hear us.
Okay.
Okay. Please, can you hear me? Dr.
can hear
John,
you.
please confirm.
Yes, we can hear you now.
Okay, sorry. Sorry about that. I wanted to share the screen. So we have Cara Lewis, and Cara Lewis is a Deputy Director of the Center for Translation, Research and Implementation Science, that's CTRIS, at National Heart, Lungs and Blood Institute within the National Institute of Health. So Dr. Lewis has a PhD in clinical psychology with expertise in advancing pragmatic and rigorous measures and methods for implementation, science, and practice. So welcome, Cara Lewis. So our next panelist will be Anchendika Mulenga. So Achendika is a specialist doctor in internal medicine and infectious diseases with a very strong passion for both clinical care and research. She has over 10 years of clinical experience and currently serves as a lead clinical mentor and researcher on the TaxPen project in Zambia, where she leads a multidisciplinary team in data-driven implementation efforts to deliver evidence-based interventions that improve health outcomes for NCDs among people living with HIV. So welcome, Chandika. And then lastly on our panel will be Rebecca Roper. Sorry. My screen is not moving. So Rebecca Roper is a program official in the implementation science branch of CTRIS, that's the Center for Translation Research and Implementation Science, at the National Heart, Lungs and Blood Institute within the National Institute of Health. So Rebecca Roper has an ED in Educational Leadership and Organizational Innovation, Masters of Public Health in Health Policy and Administration, Masters of Biostatistics and Epidemiology with integration of shared decision-making and information technology to provide pragmatic workflow that supports evidence-based care. You agree with me that we have a very, very strong panel today. So let's really take time, listen up, and learn more from them. Thank you very much. Dr. Olayoko.
Yeah, thank you. Thank you so much,
yes.
Uduak. So we have Cara Lewis that will be speaking with us, Rebecca Roper and Chindika. Pardon me, I forgot to introduce Uduak. Uduak is an Associate Director of Strategic Information on a PEPFAR HIV program that is implemented by ECUS, one of the Nisa partners. And Uduak has over a decade of experience on strategic information systems, health program monitoring, and implementation science. So thank you so much, Uduak, for joining us today. So our panelists today, the way we structure the section today, we'll have two broad presentations. So after each presentation, we'll open the space for a Q&A. So first, we'll listen to Dr. Lewis that will talk to us about implementation science and implementation mechanisms. Then we'll have a Q&A. Then we'll gather back again for a second presentation by Anchindika Mulenga, who will talk to us about some of the projects she's doing also in Zambia. Then we'll gather back with a Q&A led by Rebecca Roper. So then we'll come back and now summarize and take questions, then close. So that's how we are going to go. So thank you everybody for your patience. I now call on Dr. Cara Lewis to take it from here. Thank you so much, Dr. Lewis.
Well, you're not off the hook, John, are you? We're going to tag team today. I'm delighted about that, folks. We're going to try to bring to life these slides with a concrete example from Dr. Oluwefo's research funded by the National Heart, Lung, and Blood Institute. So let me do a quick check. Can you see my slides in slide presentation mode?
No.
Was that a yes?
No.
No, not yet.
Okay, thank you
Not
for
yet.
telling me. So do they look to be in notes mode?
Yes, notes.
No, they're just yeah, they're not in they're just showing the slide, but not in not in slideshow.
How about now? I did a swap screen. Did that work for me?
Nope.
Nope.
No, not yet.
Okay. I'm gonna try a totally different approach, folks. One moment, please. I had to go through Zoom on my browser because they took it off our computers. So let me try it this way. And then I think you're seeing notes mode. And I think you're still seeing notes mode. And now I hope you're seeing slideshow mode.
Yes.
Slideshow.
Yay! I'm a talented, tech-savvy individual. Good day to you all. I'm so delighted to be with you. I cannot see you now that I'm in slideshow mode, and I cannot see the Q&A, so I trust you'll interrupt me at any and all points that you have something that you want to bring to the conversation. I'll acknowledge that it's a pretty nerdy title you've got in front of you, centering mechanisms, which I'll define in just a moment. But I'm really hoping that this sort of advanced topic is presented in a way that really brings the foundational terminology front and center, but also makes it practical, because I really do think about implementation mechanisms as a practical way to streamline how we approach implementation, particularly in settings where we don't have a lot of resources to bring to bear. So first, I must acknowledge I have nothing to disclose, and the contents of the presentation today should not be construed as representing any official position of the National Institutes of Health based in the US or the Department of Health and Human Services, of which we are a part. And as John mentioned, it's a two-part session, and I'll take this first part, and Rebecca will join us for a Q&A, so get those questions ready. Before we dive into the content, I want to acknowledge where I sit physically today in Citrus, as we fondly refer to ourselves. That's, again, the Center for Translation Research and Implementation Science. We have 4 pillars that guide what we do as funders of biomedical research, both domestically and abroad. So we are very much engaged with and supporting implementation science that we'll focus on today, but also we have pillars of community engaged research, which will pop its head into today's presentation, as well as health inequities research and global health research. And across those 4 pillars, we really try to promote research training, career development, and research capacity building. So to anchor ourselves in the developmental phases of our field of implementation science, although many of you were probably doing this good work before the 2000s, really when the field formalized itself, what we saw researchers focusing a lot on was answering this question of what got in the way. So you see this picture, one depiction that illustrates where implementation science came to be, and it's bridging this gap between what we know and what we practice. And in the first iteration, the first decade of our formalized science, researchers were trying to surface what are the barriers that can explain why what we see in practice does not reflect what we know from the scientific evidence. And I feature on the slide in the 2000s section the article, a seminal article really by Laura Damschroeder and colleagues, published in 2009. This is where the CFR emerged, the Consolidated Framework for Advancing Implementation Science. This framework offers 5 domains of barriers and has since been updated in 2023, I think it was, and it really offers almost a taxonomy of barriers that might impede our efforts to implement evidence and evidence-based interventions. And then in the next decade, the 2010s, we saw scientists, implementation scientists, trying to answer, well, what works then to overcome these barriers? And a seminal article from that decade was published by Byron Powell and colleagues in 2012. And this offered a compilation of strategies for implementing clinical innovations, in this case in health and mental health care. And they updated that compilation in 2015. And it really gave us almost like a menu of implementation strategies or activities that we could bring into different settings to help us overcome those barriers, to bring more evidence and evidence-based interventions into play. And now in the 2020s, I'm seeing more of, and I'm excited about us answering the question, well, how does it work? So how do these strategies overcome those barriers to expedite or speed up how we get evidence into play? And I feature an article that I led, which was a systematic review that I'll talk more of in just a moment. And as I try to elaborate the why of the focus of this presentation on mechanisms, it's really about thinking practically, how do we move in a resource-sensitive way from this point A of current practice to this point B of optimized practice that is informed by evidence or that brings new evidence-based interventions into the setting. And you'll see that there were a group of US researchers. I think this article that I show on the slide was published maybe 5 years ago or less, that talks about the promises and pitfalls of implementation science through this pre-mortem exercise. And again, and in this article, they were suggesting that implementation mechanisms could help us really realize the impact of implementation as a science on the practice. And so what are mechanisms? And this is just how I think about them. They're the reasons why change occurred or how change came about. It is a process. And if you're interested in reading more in the weeds about this, there's an article we published in 2022, The Mechanics of Implementation Strategies and Measures, really trying to help researchers do more in the study of implementation mechanisms. So how are strategies exerting their effects to overcome barriers and achieve implementation outcomes of interest? And so to get us started on the work, our team did try to wrap our arms around empirical studies around the globe that were examining implementation mechanisms and make sense of what progress had been made in that space up to 2020. And it wasn't just the systematic review that we led. There was one other published in 2016 by Nate Williams. We found 46 unique studies that purported to be measuring implementation mechanisms. These showed up in 7 different countries. And just to cut to the chase, none of those empirical studies at that time had been able to establish mechanisms of implementation. And so that really showed us that we needed to offer more on the why is this important and how do you actually do this work? And that's what we'll dig into today. So about that why, what problems are we trying to solve? Well, I've got 3 at least featured on the screen for you. So unfortunately, despite the incredible progress made by our field, we see implementation strategies continuing to produce suboptimal outcomes. And when I offer this, I like to offer an example. You might be familiar with the tailored implementation for chronic diseases. It was a multinational study in Europe. And one of the lead investigators is Michelle Vensing, who was an editor for the journal Implementation Science. He writes in the introduction to the findings from that 7-year study across 5 countries, he writes that the chosen implementation strategies were not sufficiently matched with targeted determinants or not effective in the targeted groups and settings. Insights into the linkages of interventions and determinants or barriers is very limited. And indeed, that multinational study of tailored implementation for chronic diseases showed that tailoring did not outperform usual care. And so this was a huge investment and so much was learned through those studies. But we see this call for focusing on implementation mechanisms emergent from their null findings. And we see others more recently talking about the import and utility of mechanism mapping. So there was a different study that had null findings after a really big implementation trial. And Elvin Gang and colleagues write that one way to dissect how implementation strategies fail can be through formal exploration of anticipated mechanisms. So in addition to suboptimal outcomes from some really big implementation trials, we see that strategies that are being designed and tested tend to be more increasingly higher costs and complexity. And unfortunately, when we are testing higher cost complexity strategies, we worry that we could actually make it very difficult for other settings to pick up and then deploy these implementation strategies if we don't focus on mechanisms that would help us from a tailoring perspective to decrease their resource impact. And finally, we might unintentionally contribute to exacerbating inequities when we're not focusing on implementation mechanisms. We might have misalignment with strategies and determinants and exacerbate inequities. And I'm happy to dig more into that if folks have questions. So what I'm arguing is that mechanisms allow us to optimize, to tailor and adapt, sustain and spread. And I'll come back to those with some really concrete examples later in the talk. But for now, I'd like to invite John back into the conversation. We're going to really kick things off now with a concrete example of a set of aims from a study that I understand him to be a principal investigator of. John, over to you.
Oh, hi. Thanks. Yeah. I'm not the principal investigator. I'm one of the co-investigators. On that grant, we have two MPIs, Professor Zanolwe and Professor Jen Devo from OHSU. And this grant is funded by NHLBI, so we are grateful for all the support the US government has continued to provide to do this kind of work. So the community vital signs, in very brief, we set out to test strategies for early identification of undiagnosed hypertension among adults living in Nigeria. Because we realize that a lot of people are walking around with undiagnosed hypertension. And that is, like we all know, cardiovascular disease is the #1 killer across the world. So it became priority to study this. And here on the slides, you see our aims. Aim 1 was to engage stakeholders to refine the strategies that we had originally set out to use. Aim 2 was to implement the project in the community in the 12 study sites that we have within the Nisa mix and the ICON 3 practice-based research network. And aim 3 was to implement and compare the strategies. So we had a set of strategies, 3 strategies on one arm and 5 strategies on the other arm. So we felt like it was a very well-defined study and it was local, so it could help address some of the things that we are going to talk about today. So thank you, Kara. Next slide, please. So here is how we set out to design our study, and we use the EPIs in terms of planning out our phases of the study. So we talked about building partnerships, recruiting the sites, and recruiting the patients. Then they were now randomized into 2 groups, 6 sites in one arm, 6 sites in another arm. And we did community-based screening. We are going to do community-based screening for over 24,000 people across Nigeria. And one arm, we now refer the patients that are found to have high blood pressure and provide support, right? Using an mHealth Data Connect tool to tie the hospital and the facility together and also provide medication voucher. The other arm, after screening and referral, we do both the mHealth Data Connect and the medication voucher, but also follow up with facilitated care using community health assistance and text messages. And at the end, we hope to disseminate our work at Nisa and globally, and also with the stakeholders. So this is how we planned out our study. So we hope that this will be beneficial in helping to provide concrete examples for some of the things that Kara is going to speak about. Thank you, Kara.
Brilliant. Don't go too far away. There's only a slide or 2 before I invite you back. So again, we're going to get pretty complex in terms of talking about implementation mechanisms, but we'll get there one step at a time. And the first step is to really define implementation outcomes, because this is often where many of us are coming to implementation science. We want to achieve deliberate and purposive, we want the effects of deliberate and purposive actions to implement new treatments, practices, and services to be achieved through the work we're doing. So we're trying to get uptake of evidence, for example. And one framework for unpacking implementation outcomes is offered for you on this slide. This was published by Enola Proctor and colleagues in 2011, very intentionally differentiates implementation outcomes from service outcomes, from client outcomes. And there are 8 implementation outcomes listed in this box for you. There are more than 8 implementation outcomes that might bring you into implementation science and pique your interest. Another very common outcomes framework is RE-AIM, or Reach Effectiveness Adoption Implementation Maintenance. And so this is just giving you an example of the types of outcomes that we try to achieve with our work. And very intentionally, this slide depicts this like cascading effect, because the idea is if you increase adoption of an evidence-based intervention and get it implemented with fidelity, for example, you should expect to see more equity in service outcomes, or better effectiveness of service outcomes and client outcomes like satisfaction or clinical symptoms and things like that. So to bring it back to our concrete example, I put implementation outcomes on the far right of the screen. And John, do you want to say anything about the implementation outcome we featured here for your study?
Yeah, absolutely. So one of the things that we set out as an outcome for that CVS study I spoke about earlier was to identify the proportion of people with high blood pressure as one of our outcomes, right? Okay.
Great. Okay. And so enter next implementation strategies. It's sort of answering the question, well, how do we get to that implementation outcome? Well, we bring methods or techniques that would enhance the adoption, implementation, and sustainability of a clinical program or practice. And at this point in the literature, there are over 100 discrete implementation strategies from which you can choose. And there are many different ways we can organize our thinking about implementation strategies. This is one example of 6 categories: strategies in the plan kind of area, doing needs assessments, doing site visits, strategies that might seek to educate. So we offer educational meetings, or we make trainings dynamic. Financial strategies, we might alter incentives to deliver an evidence-based intervention. Restructuring strategies could look like revising roles in a care team or changing systems. Quality management strategies include things like the commonly used audit and feedback, or bringing advisory boards to bear. And finally, policy context-like strategies, changing requirements or liability laws. You know, the process for selecting strategies has looked a lot of different ways. We've seen train and pray in the early years, where we offer an educational training and we just really hope that that'll stick. We've seen the kitchen sink approach, where we throw everything at a community and really hope that one of those strategies will work for each of the individuals involved. We've also seen the one-size-fits-all strategy, where we really invest in a handful of activities and hope that that works for the host of humans. And then Martin Eccles coined the Islagiat approach, which is, it seemed like a good idea at the time. Let's see if we can bring this more concrete back into John's study example. If you want to describe the one we featured here.
Yeah, absolutely. So with that outcome that we had set out to achieve, one of the strategies we used is a community-based blood pressure screening using the Healthy Beginning Initiative, which is a very strong evidence-based, community-based platform for identifying diseases of public health importance. Especially, this was previously funded by the NIH and was found to be really very effective. So that's what we are using as a strategy for this example. Thank you.
Great. So you might be making the observation that the implementation strategy is pretty far away from the implementation outcome on this causal pathway that we're building. And that's intentional. Even though implementation outcomes are thought to be more proximal or closer to us than clinical outcomes, for instance, they're still pretty far away from that strategy exerting its effect. And so what I asked John to do was also give us a glimpse into a proximal outcome and an intermediate outcome of that strategy. The idea being that we should get a signal that strategy is operating in the way we hope it would much earlier than seeing the percentage with high blood pressure decreasing. We should get a sign or a signal proximally and then intermediate to show us that this is working. Do you want to describe those two outcomes?
Yeah, absolutely. So one of the things we thought would be a very good intermediate outcome was that the community health advisors that we had recruited in the communities, churches, and mosques are actually doing the screening. Then a proximal outcome was that the communities and the clergy actually endorse or adopt the HBI intervention, because without their support, essentially, the community health advisors will not be able to conduct the screening. And if they don't do that, then we will not be able to even identify people living with hypertension that do not come to the hospital.
Brilliant. Thank you for inserting that. And next up in our causal pathway, we introduced determinants of practice. That's our jargony term for factors that obstruct or enable changes in targeted professional behaviors or healthcare delivery processes, or in community partnerships that intend to deliver evidence-based interventions. We commonly refer to determinants as barriers and facilitators. And over the years, we've actually seen it possible that 601 unique determinants of practice can emerge across settings, even in a single project. So that tailored implementation for chronic diseases study I mentioned at the beginning, a study led by Krauss and colleagues did surface 601 plausible determinants. And these determinants span multiple domains. So just as an organizational offering for you, we've got patient, provider, organization, community, and policy level determinants. Like I said, when I was describing the CFR, or the Consolidated Framework for Implementation Research, they organize determinants in a different way. They have inner setting, outer setting. They have the intervention, the process, and individual characteristics as a way to organize determinants. But needless to say, they often are the factor that gets in the way of evidence or evidence-based interventions from being implemented. And so strategies are often trying to resolve barriers. So let's come back to our example. John?
Yeah, thank you, Kara. So one of the barriers we thought would limit the work that we wanted to do was poor healthcare utilization. Generally speaking, in Nigeria, only about 10% of people have health insurance. So that is responsible for people not even going to the clinic. But even in the communities, some people do not even believe in Western medicine, and the belief system is different. So we were like, if we could help to address poor healthcare utilization, which was a barrier, then it could help us move us towards the goal and the outcome that we wanted to achieve. Thank you, Kara.
Great. So this is where we bring mechanisms in. So recall, mechanisms are the reasons why change occurred or how change came about. It is a process. We often put a label on it, a process that is multiple steps and is hard to measure. But so let's come back to our example. And what mechanism did you articulate here?
We felt like the biggest mechanism to addressing this barrier was building community trust. And that was what we set out to work towards.
So I want to elaborate here, John, if I may, to say that your example really underscores the import of articulating mechanisms when you're planning an implementation study. Because if you look simply at the barrier, poor healthcare utilization, you wouldn't necessarily construct the implementation strategy that you did if you didn't know very clearly that you needed to activate community trust. Because poor healthcare utilization, maybe we could overcome that by changing policy. Maybe we could overcome that in some sort of logistical strategy solution where we try to increase access, for example. But you knew your setting well and your population that was intended to benefit. And you understood, I believe, that the poor healthcare utilization could be overcome by building community trust through the strategy. Let me pause and hear your reaction.
Yes, absolutely. Like I said, there are multiple belief systems, and the way we designed our study was working across 12 sites in the 6 geopolitical zones, because some parts they have more Muslims, they have more Christians. Some parts they have different ethnicities. So there are so many different belief systems, and understanding and documenting those belief systems will help us, right, to build the appropriate trust where necessary. And like you said, one size fits all is not, we shouldn't be what we do. So we are tailoring our approach. Building trust is a broad approach. So we use that as the umbrella, but when we get to the community, we know what it is that we need to address to help to build trust.
Excellent. Thanks for elaborating on that. And just to bring in some other examples for folks, you're seeing a causal pathway of an implementation strategy being unpacked using these shapes and symbols. But another way to do this work of thinking really intentionally is even just in a table with columns, where you're clear about what implementation outcomes on the right that you're trying to achieve. You have a sense of the determinant or the barrier that's going to get in the way. And then you think really carefully, what mechanism do I need to activate? And therefore, what strategy do I need to design and deploy? And as a couple other examples, if you were trying to achieve fidelity to the evidence-based practice or doing the evidence-based practice as it was intended, maybe one of the determinants or barriers is a skill deficit among those intended to provide it. And so you need to activate this ability to acquire and refine skill and grow mastery. Well, you could probably achieve that or activate that mechanism through training as long as it had corrective feedback. But without that corrective feedback, you're unlikely to grow mastery and overcome that barrier. A couple more examples. Oftentimes, and I saw this in the Menti results, at least the early ones before I took over the screen share, that a lot of you are here because you care most about sustaining an evidence-based practice. Well, what often gets in the way of that? Turnover of the people who are trained or equipped to deliver the evidence-based intervention. So you need to activate this embedding of expertise in order to overcome turnover to achieve sustainability. And you might deploy a train the trainer approach in order to do just that. And I think I'll skip over these other examples just in the interest of time and acknowledge we're not yet done with our causal pathway. So when you're building an implementation plan and choosing discrete strategies, one really important thing to think about are preconditions for the mechanism activation. So these are factors that are absolutely necessary in order for the mechanism to be activated and for subsequent causal events to occur. That sounds very technical, but think about this as a light switch. You cannot make the strategy achieve its effects if you don't turn something on. And so what we're getting at here is that a certain set of circumstances or factors need to be on or present in a community in order for the causal pathway to unfold, in order for the strategy to work. So let's bring our concrete example back in. John, over to you.
Yeah, so for the mechanism here, our precondition was that one of the things we did was to make sure that our research staff were employed from those particular communities. They live there, they understand the systems, they understand the beliefs, preferably they are of the same ethnicity. Most definitely they speak the language or the languages in those communities. So we employed 2 sets of staff, site research coordinators who work primarily in the hospital but also in the community. But we also had community research engagement officers who were employed from those communities. So that was one of the preconditions that we felt would be very appropriate for our setting. And for the other one, we also felt like it's important that the clergy are in support of what we are doing, but also that the people buy into the clergy's discussion and talk and encouragement, which we felt was very important. So those were the 2 preconditions that we set for this study.
Great. And just to, maybe state the obvious, that if you're trying to activate this mechanism of building community trust, that explains why the precondition of research staff being employed from that community is critical. It's hard to believe you could activate community trust if research staff came in from the outside and tried to drive things forward. And then on the precondition for the proximal outcome, if you're really hoping to see that signal that the communities and clergy endorse the Healthy Beginning initiative, you need to make sure that the folks that you're really trying to reach with the intervention actually engage with the clergy then. So I'll move on to our last component of the causal pathway, and this is the moderator. So from a technical perspective, these are factors that are believed to strengthen or weaken the relationship between the strategy and the mechanism. So to stay with our lighting analogy, think of a dimmer switch here. So when you have a moderator in place, you can amplify or turn up the power of the light or the strategy. And in some cases, certain factors will dull the effect of an implementation strategy. So you can hear me describing why it's important to try to go into an implementation process knowing what moderators could emerge so that you can actually try to target them or amplify them or overcome them if possible. So back to our example, John.
Thank you. So the moderators that we were able to identify here is that the clergy routinely or typically focus on health topics in maybe when they are giving some of their sermon or even as part of their regular discussion within the community, either a church or a mosque or other traditional settings. And for moderators, for the other part, for the precondition for vulnerable population, we talked about logistical barriers to primary healthcare access, which we already know some people can't go to the clinic because they don't have money to go, or there are other challenges like we talked about, even having health insurance coverage, simple things like that that we take for granted in high income countries. They are significant moderators here.
Excellent. Thanks for elaborating on those moderators and hopefully bringing something really technical to a concrete space that helps those who are listening in today understand why you designed your implementation approach in the way that you did. And mechanisms are the red diamond in the middle that are often overlooked by implementation teams in their design phase. And that often, when we look back on null findings or failed implementations or those that achieved suboptimal outcomes, it's because the mechanism wasn't articulated and the strategy that was picked couldn't actually activate that which it needed to in order to overcome barriers and get to those outcomes of interest. I've got a handful of other slides, and then we're going to open it up to conversation because we've got so much more great stuff coming next with Drs. Roper and Mugala. So let me move through these quickly. I had some really in the weeds examples for these, but I'm going to skip them in the interest of time and just acknowledge that, again, if you're articulating mechanisms like we just did for this research example, it helps you select what strategies you might choose to bring in. It helps you match the strategies with the barriers that you are aware are getting in the way. It helps you tailor if you need to adjust your strategy for different communities or different contexts. And articulating mechanisms can also help you optimize, or in other words, streamline or improve an implementation strategy from its original form. And so if this has piqued your interest at all, please consider articles featured on the screen by the study team I came from before I joined the United States federal government in my role. There are, I think, pretty accessible articles. In particular, theorizing is for everybody. So Rosemary Mesa wrote this article a couple of years ago and really tries to help folks from the researchers to the practitioners think about how could this causal thinking be brought into a planning of an implementation approach. And then if you like the couple peppered in comments about optimization, here are a couple articles that really think through that optimization approach methods in the space of implementation science. So you've got Kate Guastafaro and Linda Collins, who really are pioneering this multi-phase optimization strategy approach. And then Donald Spiegelman and colleagues have the Learn As You Go approach that they've brought into the HLB Simple Alliance and in other spaces that you might be interested in. Couple more resources for you. The studying implementation mechanisms is really complicated if you're bringing that into a research project. We recently published a research agenda to help advance the study of implementation mechanisms, and this came out of a 3-year conference grant that we got from the United States Agency for Healthcare Research and Quality. And so there are unique actions that many of you in the virtual room today could take to really advance the study of implementation mechanisms. And there's a handful of other articles in a special collection that you can check out if this work is interesting. And sometimes I feel the need to acknowledge that other leaders in the field think this work is important. So when we saw the editors of Implementation Science and Implementation Science Communication put an editorial out in 2024, they featured even in their abstract the importance of studying implementation mechanisms to be able to push the field of science and practice forward. This next real busy slide just features some incredible advances the field of implementation science has offered over the last 2 or 3 decades. We have the causal pathway diagramming that I showed you today. We've got theorizing that is really being championed by Roman Kisloff and colleagues in Europe. We've got logic models coming out from J.D. Smith and colleagues. We've got mechanism mapping. These are all related approaches, but different with different purposes. We've got strategy specification tools from Justin Perceau and colleagues in Canada. We've got strategy reporting recommendations so that we can make our work more replicable. We've got this dialogue of form versus function that might help us when we think about tailoring and scaling and spreading. We've got core component adaptable periphery distinctions that can help us parse and move nimbly. I've mentioned MOST as a complement there, as well as thinking through adaptation, fidelity consistent adaptation, strategy modification, tailoring. How do we bring strategies into the nuanced local contexts in which we work? And then how do we track what we're doing in a way that others can benefit from the excellent efforts that are being made? So I hope we'll share these slides and you can look into each of these articles and think about the advances from implementation science and bring them into your own work. And to that end, please reach out to Citrus, Rebecca and I and others for technical assistance. And that's when program officers from the National Institutes of Health and in specific, the National Heart, Lung, and Blood Institute can offer you guidance and reactions as you navigate the various opportunities at the National Institute of Health for funding your work and the scientific ideas that you're initiating and we need to see more of. So keep in mind this particular funding opportunity. It's the Dissemination and Implementation Research in Health. And I think all of your speakers across the week, their institutes are signed on to this particular funding opportunity. So depending on what kind of clinical conditions you're studying, you'll probably find an institute that's willing to work with you and offer that technical assistance. And our colleagues who weren't able to join us today for this session are listed here. You can send us an email, share your draft aims for your science, and we'd be delighted to meet with you to offer support. And although we're communicating a little less frequently these days because our hands are pretty full, you can follow us on LinkedIn and important updates about implementation science will be posted there for you. So on that note, I'm going to stop sharing my screen and see if I can see you all again. I got to thank John for joining me. Folks, you might not be aware, but it was 3 days ago we decided to tag team and embed his study in these slides, and I thought that worked out really well. So thank you for coming to play. That was really, really cool. So let's open it up.
So thank you both. If I can just take a prerogative. So I thought it really did go well with the illuminating how to apply these approaches. But I had a question for both of you. Back on slide 27, and you talked about, Kara, that the mechanism is sometimes overlooked and it's a critical identification. Would you both think one way you can mitigate that happening is you really have the folks on the ground who are asking the quality improvement question? I want this to go better. This is my concern. Is that, how do you, the pragmatic approach is so important, that's married with rigor of research. But John and Kara, the folks on the ground, they watch what's not working, or they have an idea what's not working. How do you facilitate that?
John, do you want to start?
So I'll start, then I'll let you wrap up. I think for many of us, right, especially I started my career as an implementation practitioner, and we don't think through the whole spectrum of what we want to do. We know what we want to do, we know what the results are, but we don't think through how it's going to happen, right? And I think that's where the role of the mechanisms come into play, for folks to think through and say, yes, this is what I want to do, this is what I want to achieve, this is the strategy I think, but how will this strategy actually make this thing happen? If we pause to think about that, perhaps the issue around mechanisms will be a bit clearer. I'm not an expert yet, I'm still learning, but over time, I've realized that if we pause and really think about it and ask ourselves, how will this A strategy lead to B outcome? Then we'll be getting closer to understanding the mechanisms. And once we understand the mechanisms, we also get closer to understanding the other things that we talked about, like the mitigating factors, and the preconditions and the moderators. Is that not skipping over that process? Sometimes in hurrying to implement a project, we don't pause to think about it. But in my mind, my major takeaway from all of this is you need to pause, right? Even when you define your outcomes, you define your strategies, you need to pause and ask yourself, okay, how is this strategy going to lead to this outcome? Kara, over to you, please.
Sure. I want to underscore something you said, and I was smiling because when our team was developing this causal pathway diagramming approach to designing implementation strategies, we kept saying we really just need to slow down, right, and think about how do things work. And Rebecca, what an astute observation that like the folks on the ground are the best people to unpack and lift up mechanisms. And it's true, because you can find a determinant, like the most commonly cited determinant is time. But if you don't understand why is time and why and how you need to overcome it, which can only come from the folks on the ground who, might bring that quality improvement lens, or at least the lived experience of the folks delivering the care, then you might stand up the wrong implementation strategy. And that's why I had John really elaborate on why was it about building trust, because you really could throw another implementation strategy into the mix to overcome, healthcare utilization challenges. But if trust is a big thing you need to activate, you're only going to learn that by talking with the folks in the community.
So thank you. Someone else had a great question. Dr. Tita Brooks was asking, and she apologized. You may have addressed this in the beginning, but when you were talking on slide 27 and John was giving his example, she wanted to know a little bit more about the theories, models, and frameworks that you considered. If you could, John, when you were designing the CVS clinical trial.
Yeah, so for the CVS studies specifically, we are using two major frameworks. We are using the EPIs to plan out the study and the phases of the study, and we are using REAIM to measure or to evaluate our study, right? So, but the diagramming that Kara has shown, I think, is from the causal pathway thinking. That's the diagramming. So I hope that answers the question that was asked.
Well, and maybe I'll just reflect on John's response to say we often are pulling in multiple theories and models of frameworks in a single study. And so you can hear they pulled in an outcome framework, they pulled in a determinant framework or model, and then theoretically, we are theorizing through the causal pathway diagram, all in the same study. And when it comes to articulating mechanisms, we've heard a lot over the years that people would like a taxonomy of mechanisms. And if that's you, if you're looking for a taxonomy of mechanisms, you can look to Susan Mickey's group in the UK. They have really taken off with the behavior change wheel, and they have a website. It's called the Tools and Techniques website. And in the Tools and Techniques website is this unpacking of behavior change techniques, their mechanisms, and the evidence for those. It's not an exhaustive list, though. And what you might see with their work is that because it really comes from the health promotion space, there's a lot of intrapersonal, so within the individual types of behavior change and mechanisms that follow. And we know with implementation studies, particularly when we're trying to scale things, we've got outer context, we've got policy, we've got multi-sectoral types of determinants. And so our mechanisms need to also take on those multiple levels. And that's where something like the Theorizing is for Everybody article can help you create these little micro theories for your study, for your setting, for your context, but also bring in these grand theories that come from other disciplinary spaces. So I'll leave it there for now.
Thank you, Kara. Other questions? Anyone? So please keep posting your questions in the chat so that we, by time, we'll move on, right? Rebecca? Okay, I see Dr. Zanole has his hand up. Please go ahead.
And thank you so much. I enjoyed the team talking. It was really nice. It was really, as you were building that out, I was looking at it and it was looking so exciting actually. So to think it through, I think what John was saying is a lot of people don't take that time to stop and think it through. And they keep saying, there's something they say in Nigeria, let's be going. Let's be going means as we go, we'll figure it out. But sometimes that's true. That's what happens when you start implementing. But you also have to think about so that if something changes, you will know that something has changed. The one of the things I wanted to ask you is you're thinking about mechanism. How does mechanism differ from mediators?
All right, we're getting really technical now, are we? It's a good question. And so, some of the literature will suggest that both moderators and mediators can point you toward mechanisms. But they themselves are not necessarily mechanisms. Mediators in specific are often drawn in a statistical diagram, right, as the middle pathway between a strategy and between an outcome. And so, the short answer is you could conflate them and that would probably be okay. But really, as we are trying to establish mechanisms, these processes that are hard to directly measure, we might test the same mediator in different contexts in several studies to see if we can replicate through manipulation of a strategy that same pathway to occur. And we might not find that the same mediator does get activated, but there could be the same mechanism showing up. And that's not necessarily the most helpful response, but mediators and mechanisms can be thought of as almost the same thing, but they aren't always. I don't know if that's helpful.
Thank you. I remember when earlier in my career, and I was working with a statistician, and he said, "Oh, we're going to look at, we're going to do mediation analysis or mediator analysis." And I looked at him and I turned back and said, "What the heck is that?" And so again, but as you break down, you understand that if the understanding the mediators, understanding the mechanism help you to tweak, like what Rebecca was asking, when things are not working well, then you ask yourself, what were you expecting? How did you expect it for it to work? So John said we gain the trust of the community. Sometimes that actually is not easy. It sounds easy, but you have to remember, even in Nigeria, we are working in the 6 regions of the country. And you may go in this place that you don't even speak the language. So it's Nigeria, but we know that there are multiple language. Okay, so maybe you understand the language and you go there and find out they're different, they're religious different, so things that may have worked in the churches wouldn't work in the mosque. So you have to make an adaptation for those things to work in the mosque. Just by simple, you wanted to do something that you wanted an interaction between a male and a female, a husband and a wife, and in the churches, they worship together. So you could get that to happen. You go to the mosque, the women worship differently, the men worship differently, and that same thing won't work. And then you have to understand why it's not working and why put pathway that is working and be able to make adaptations to that. So I think those are part of the things that thinking those times through really does help. Thank you for explanation.
Yeah, no, the great additional examples. And that's why I was suggesting that I think if we center mechanisms or mediators, then we can go into different contexts and still try to overcome a similar barrier, but we can adapt, we can tailor, and we can adapt with more ease. So I'll leave it there. Thanks so much for having me today.
Kara, before you go, just one question, then we'll move on to Dr. Achindik and Rebecca. So there is one question in the chat
Yes.
by Victor Uka. It says, how do contextual factors, e.g., organizational culture, leadership support, how do they interact with implementation strategies to influence the mechanisms of change that lead to successful adoption and sustainment of evidence-based practices?
Great question. Not easy to answer. The short answer is that oftentimes our contextual factors show up as those moderators, or they show up as preconditions. So for instance, if you had an implementation strategy that demanded leadership support because it was the strategy was a leadership organizational change strategy, if you didn't have leadership support, you couldn't do that strategy. So in that case, it's a precondition. But organizational culture, well, gosh, if you had a learning culture, that could be a moderator and really amplify the impact of an implementation strategy, right? If you were doing something like training as an implementation strategy, if you had a learning organizational culture, that training might have a better uptake and impact than if you didn't have that kind of a culture. And there are some cases where those contextual factors might actually be a good label for the mechanism itself. I'm trying to think on the spot of a good example of that. And what I'll add here is implementation climate. So that has been a theorized construct that some people think of a contextual factor, but you can actually activate implementation climate through a strategy. So implementation climate reflects the extent to which an evidence-based intervention is expected, rewarded, and supported by an organization. And so if you can activate any of those elements of implementation climate through your strategy, that might be exactly what you need to overcome a specific barrier and achieve an outcome. So I guess the short answer is it depends, and everywhere along the causal pathway. How's that?
Yeah, excellent answer. Thank you so much. And I like the way you defined implementation climate. Very simple. Sometimes we get lost in the weeds, but where those expectations are clear, where they are seen and when they happen, right? So thank you so much. So I'll hand over to Rebecca and Anchi for the next presentation. Thank you.
So thank you very much. Thank you all. So I have the pleasure of introducing Dr. Anshi Magula, who's going to give us her real-world experience as a clinician, implementation research scientist, and then we're just going to chat a little bit afterwards, and you're open to ask questions for her perspective and experience. Welcome.
Sorry, I was muted. Thank you so much for having me. I don't know if I should go ahead and share my slides.
That would be lovely.
Okay. Just give me a minute. Okay, I have my slides up now. Would you like me to go ahead or?
Yes, please. If you can put it in presentation mode, and we look forward to the information.
Okay. All right. Hello, everybody. My name is Anchi, commonly called Anchi. So I'm part of the TaskBen team, and I'm going to share, the TaskBen experience and some of the implementation science lessons that we've learned through our journey. I think a lot of what I'm going to say is basically a practical aspect of what Kara and John were discussing. So first off, I just want to start by first acknowledging, of course, our sponsors and also acknowledging um, the consortium that I belong to, which is the HLB Simple. So this is an alliance that basically aims to advance the field of cardiovascular health in HIV care in Africa. And there are 6 African countries that are part of the HLB Simple. And these are the countries, and these are some of the faces behind some of these studies. Some of them you might know very well. So we have Uganda, Nigeria, Botswana, and of course Zambia, Mozambique, and South Africa. So without wasting much time, I will dive into what TaskBen is about. So TaskBen is a clinical trial that aims to study the effectiveness of a package of evidence-based interventions and implementation strategies that are based on the WHO PEN and have been adapted for people living with HIV and cardiometabolic conditions in Lusaka, Zambia. And we are in 12 primary health facilities right here in Lusaka, Zambia. So I will talk about the 5 pillars that are, that make up this strategy, this implementation plan. So the first part is the integration of care, of course, for HIV and NCD conditions. Our whole aim is to create a one-stop shop where the HIV patients get enhanced screening and diagnosis as well as care for their NCD conditions. And so this, the whole point is to try and prevent fragmentation in the healthcare for our HIV positive clients who might need to visit multiple clinics because they have both HIV and they are suffering from one NCD condition or the other. And then, of course, in doing so, we have developed some guidelines. So we've contextualized them to the Zambian setting, of course, being adapted from the WHO PEN guidelines. So that is our evidence base. And we introduced this guideline, which we refer to as the TaskPen care guideline. It's introduced to the healthcare facility or the healthcare facility workers before the implementation takes place in their facility. It's a pretty detailed training that we do through this guideline. The whole point is to introduce new information, to sharpen the information of the healthcare workers. And this allows for what we refer to as task shifting. So in TaskBen, and you guess that's where the name actually comes from, we task shift. In order to integrate the care of HIV and NCD conditions, obviously that increases the work burden for the healthcare workers. And to alleviate that, we do what is referred to as task shifting, where we empower the non-physician healthcare workers, the voluntary staff that are working in the clinic, with the knowledge about the NCD the NCD condition that we're looking into, how to do basic screening and how to do a basic diagnosis, especially for the nurses, just to ease the pressure off the clinicians and for the cascade of care to flow. So there's aside from the pre-introduction training that we do and the capacity building that we do, we also do what is referred to as on-site training and mentorship through a strategy we refer to as practice facilitation. And I'll get into that later. So the other pillar is in order to, strengthen this care for NCDs among those who have HIV in the primary healthcare setting, we knew that we needed to strengthen the electronic monitoring records and also provide audit and feedback at the facility. And in doing that, we included a dedicated NCD module in the already existing electronic monitoring record. So basically, just to track back a little bit, TaskBen builds on what is already existing. So it builds off of the HIV program, which already has an existing electronic monitoring record, but it's a system that initially was not built to look into the or even record or monitor and track NCD conditions of those patients who have HIV and are visiting the clinic. So we came through and we built a dedicated NCD module. This module also has enhanced decision support, so prompts for the clinicians who are working to know what is abnormal, what is not normal, what needs to be done, what next step to take. And then also through building this electronic monitoring record, as we all know, EMR needs to work with power. It needs to work with internet. So this has also led to us, stepping in to help with power backup support, hardware support, technical support in some cases, training as well, because of these new components that we'll be adding. And then this has helped us to generate data for audit and feedback and data review meetings with the facility staff. And then we have the cardiometabolic testing. So the diseases themselves, this is integrated care. Of course, there's enhanced screening, and I've already talked about the task shifting, but then the conditions that we're looking at, we as TASPIN focus on diabetes, dyslipidemia, and hypertension. So diabetes and dyslipidemia, we want to provide an evidence-based way of diagnosing these conditions, and that would mean doing certain tests, okay? But then because we want to integrate the care and make it a one-stop shop, we have introduced point of care testing and confirmation of diabetes through doing the HbA1c for those patients that have high RBS readings, and then also doing lipid profiles to diagnose dyslipidemia. And so we've introduced certain machinery as well as technical support, but that has also come with on-site refresher training that may need to be revised based on the need or the turnover of staff at the facility. Then the fifth pillar of this package is basically strengthening the NCD medication supply chain. So we were going into a space that was just basically built for HIV and HIV medication, and as again, not for NCDs. And so our approach was not really to start providing medications as a study and make the clinic dependent on us, but to change the way things are done and have NCD medications also stocked in the HIV pharmacy so that a patient doesn't have to go out to another pharmacy to get medication for their NCDs. And so that has meant basically turning the clinicians and the pharmacists into, advocates for these NCD clients as well as their conditions, improving the supply chain communication between the central storage with the facility and all of that nuances, and just really making it streamlined. It's very surprising that this process can be very complex. If you've worked in an African medical setting before, you know that this is something that really needs to be worked out. And then aside from that, because people with HIV are already accustomed to multi-month dispensing, so 6 months and all that, we also introduced a multi-month kind of dispensation for NCD medication, but only for those kinds that are stable. Of course, those that are newly diagnosed or have NCD conditions that are still unstable, we tend to have a very shorter review time for them. So this is basically just the pillars of this package of evidence-based interventions that drive the TASPEN program forward. So Sorry. This is just an illustration of what we do as TASPEN. So there's enhanced screening, okay, for the NCDs for these patients who's come through to the HIV clinic. We screen them for diabetes, hypertension, and dyslipidemia. We've refined the screening process. Believe you me, there's a proper way of taking a blood pressure, and we make sure that that is properly done and recorded. I talked about the EMR strengthening, so smart care and everything that comes with that. Then this shows the point of care testing that we have introduced at the facility, and then the TASPEN clinical guidelines as well that have been introduced. And then of course that does come with retention. So not just retention for HIV medication, but also follow-up and retention for those clients with NCDs. So what is showing on the screen is basically the whole cascade of care in terms of an integrated approach to the management of NCDs for clients with HIV. So starting from the screening, making sure that we diagnose the conditions, going into the treatment, making sure that they get the appropriate treatment that they need to get through the clinical guidelines, and then of course making sure that these clients are retained to care. And this is the cascade of care that we are basically looking at in the clinics. So when it comes to practice facilitation, this is a strategy that we use, or maybe you can call it a mechanism, that provides ongoing coaching and support to facilitate the changes that we have introduced. And usually what I love about practice facilitation is that it's designed and it's tailored to a particular practice's unique needs and context. So it's a very contextual way of doing things. And so it's a tailored coaching, but it's a continuous coaching. So it's not just basically throwing knowledge at the healthcare workers and then walking away and then expecting, results, but it's working with them, training them, intensive training, but then working with them step by step to see how this intervention is working at their facility. And one thing that I've come to see in my experience is that it's not the same thing that is done at every facility. Different facilities have got different ways of doing things. And so this is where practice facilitation does come in. I included here the 5 A's, which I use cyclically through the facilities as we go. So basically, we assess and see what is your way of working, how are things done at the facility, and we advise them on how they can integrate the care. And of course, we don't force them to take what we're saying and to do things the way we want to do. We always want the healthcare workers to drive this process because we want it to sustain itself. So the difference between forcing something on people and letting them make the decisions, I think does impact on sustainability of the program that we've introduced to them. I mean, there's so much that we're introducing. We're introducing knowledge, we're introducing EMR, we're introducing testing, retention, and the guidelines, and we just work with them to see how they can integrate this in their normal way in which they do things in their standard of care and integrate the care for NCDs as well. So we agree with them in how they can rearrange their systems, and keeping in mind all the time that cascade of care that I was already talking about. So just basically an overview of how I think TASPEN has contributed to the development and sustaining of healthcare programs, especially, of course, the HIV program. I believe it has definitely has improved health outcomes and has the potential to go on enhancing the care for HIV and NCDs because we are introducing more refined ways, more evidence-based ways of screening, proper ways of taking blood pressure, and then evidence-based treatment that have been contextualized to the Zambian context, of course. And then, of course, strategies to make sure that patients are retained in care in this integrated service delivery model. It does strengthen the health system building blocks because we have used implementation science basically to develop a scalable, practical solution for improving primary healthcare service delivery, electronic monitoring records, as you already heard, medical supply chain as well. It does build local capacity and works to improve the quality of care through the training and the mentorship of the local healthcare workers from the beginning, the formal training, the informal mentorship. I have seen where someone who's just a volunteer or a community healthcare worker or what we refer to as peers who don't really know anything about NCDs understand what hypertension is, what diabetes is, what dyslipidemia is, learn how to screen, and even learn how to make a basic diagnosis. At least they can say this is hypertension grade 1, grade 2, grade 3. This patient actually requires a screen for dyslipidemia. This is pre-diabetes, this is diabetes. And it's just been amazing to see how that, it has improved the knowledge of patients and how they can take over some of the things that they have ability to do at the site, leaving the clinicians really to focus on the treatment of the patient. Then TASPEN, through its work, through its collaborations, has definitely built research capacity among us. Of course, I'm the recipient of that. I think this is very key in fostering potential sustainable, results to what we're doing. It's not enough for us to just be, data collectors and just pushing things forward and just to be like foot soldiers. But we've been introduced to implementation science. Personally, I've had some formal training in implementation science now and in grant writing and building research. I feel like this will help us even to speak to future research and even future improvement of what has been introduced by TASPEN long after it's gone. Then, of course, definitely this is another informing policies, another health system strengthening building block, speaking to governance. The whole point of TASPEN is basically to inform the government, the local government, on how an integrated approach to the care for HIV and non-communicable diseases, the ones that I've already mentioned, can be achieved. Okay, and therefore, the whole aim was to influence governments to push this agenda forward, and so far we've seen very positive response to that. The government can't wait for us to finish. They're already integrating it and implementing it in other non-TASPEN clinics, which is a good sign. The national HIV guidelines or program custodians, we've had consultative meetings on how we can actually incorporate this into the national guidelines themselves. So you can see that definitely does inform health policy. And then just to talk about some of the implementation science lessons that we've learned, basically, to promote scale up and sustainability of evidence-based practices, it's important to assess capacity for scalability early on in the trial and while the research is still ongoing, rather than just plan for scale up without assessing for capacity for scalability. Because if you don't assess that, sometimes I think that's where the scalability and the sustainment might not work. And then, of course, examining the transportability and contextual relevance of implementation strategies that we've used can provide insights to improve the care of other highly relevant NCTs, not only in Zambia, but in sub-Saharan Africa. I think we have a lot of lessons to share, a lot of things that we've learned in our journey through TASPEN. And I think these are lessons that can be applied even as other researchers try to, implement the care for other, NCTs like chronic lung diseases or something like that in our African setting. Then, of course, I've already touched on it before about how our implementation efforts need to incorporate strategies that strengthen health system building blocks right from the beginning. And I've been privileged to work with other members from the consortium doing some cross-network research, and we are trying to examine the key building blocks that have been necessary for the integration of hypertension care among people living with HIV. And we've seen that some of the building blocks are common across all sites. I mean, this can inform future studies, future research, and people can already know what works and what doesn't, what is difficult, and what can be more challenging right from the beginning. And of course, this can, the same way that we are basically benefiting from, evidence-based knowledge that has been found to be successful in other parts of the world. I think it can also be translated the other way around, especially when we look at, vulnerable populations, including those with HIV. I think some of the challenges might be helpful to be adapted even in the United States among populations that may need this kind of intervention. So this is just a picture, basically just showing the whole team behind me. It's a whole team, it's a huge team. And I think everyone has been instrumental in doing the work that we do as TASPEN. Yeah, thank you.
So
Rebecca,
thank you, Anchi. If people would put their questions in the Q&A. If I could just say thank you. And I have a few questions for you, but I wanted to elaborate on my personal opinion of how your study informs the United States as well. Your study integrated into a sophisticated EHR to build shared decision support, to have a downstream effect. How does what you're finding out inform the supply chain? You're doing that sophisticated, realistic, holistic systems, Anchi, which is amazing, while also having to deal with power outages. I mean, it both has to rise to the occasion of infrastructure being sometimes challenging, but with a means by which is at the leading edge of how the system can be used. And I think you and your team need to be recognized for balancing those competing demands upon you and the skill with which you do that. Do we have anything, John? Evidently do. We have some questions and answers.
Yes, we have 2 questions here.
Wonderful.
Do you want me to read them out?
That would be lovely.
Okay, great. So Anchi, thank you so much for your presentation. Excellent. Thank you so much. So one of the questions is from Deborah Alu. He says, thank you for the presentation. I'm curious to know who paid for the NCD medications, and if the grants did, how will you ensure sustainability?
Yeah, that's a great question and something that we looked at in our cross-section study. One of the major challenges that we found across all the sites, across all the countries actually, is funding for NCD medication. So what I said was we worked through the existing governmental supply chain. Okay, so Zambia has a central supply chain for medications, but the way that it's distributed to the facility is very fragmented. And that's what we're trying to integrate. We want NCD medications to be provided in the NCD, in the HIV space. So one thing that we do is to make sure that the communication between, the government and the facility, the clinicians, the communication is open. We've had to come up with a pharmacy liaison between the government and the pharmacist. But I must also say that there are times when drugs do run out completely, both in the facility and even at the central supply level. So that's where TASPEN may come in. So we have a buffer stock as a study for certain medications, which we do supply in cases where there's extreme stock out. But I think what I can say from what I've seen is supply chain has improved because you see, we have created demand by improving screening, by improved case detection. There's demand. I think they can see the numbers and even the supply of the medication to the facility, through the whole system has improved over time. I hope that helps.
Thank you, Anchi. Excellent. Thank you. I'll follow on with the second question, then I'll hand over to Rebecca if she has other questions. So, the second question here says, well, there are multiple questions all rolled up in one. So it says, thank you so much for the great presentation. I'm doing a study in Nigeria on effects of NCDs on HIV treatment outcomes. So I'm excited about what you just said. So one of the first questions is this program only in Zambia? And if yes, is there any plan to go to other countries? Then the third part of the question is, do you provide care for all NCDs or just some of the NCDs? And is this NCD care, is it free for those living with HIV? Dr. Anchi?
Sorry, I was speaking while muted. But as I had introduced earlier, we are part of an alliance, the HLB Simple, and there are 6 different countries looking at the integrated treatment for at least hypertension across 6 different countries. So there's Uganda, there's Nigeria, the market study in Nigeria, there's Botswana, there's Zambia, Mozambique, and South Africa. Of course, these studies are being done slightly differently, but the general idea is the same, to improve the care for NCDs among those living with HIV. So I don't know if that answers the first question. Then I think the second one was about, sorry, could you help me there, John? That was the second question.
So the second one says, okay, so you've answered the first. The second one was, do you plan to expand to other African countries? You answered. I said, do you provide care for all NCDs or just some of the NCDs? And the care for NCDs, are they free for people living with HIV? Those are the 2 questions.
So yes, so the care for NCDs for people living with HIV is free. It's free of charge, and we provide care for diabetes, hypertension, and dyslipidemia at the moment as TaskPen.
Okay, so diabetes, hypertension, and dyslipidemia. Thank you so much, Dr. Anchi. Rebecca, follow-up questions? Any?
So you talked about capacity building, Anchi, and could you just share with us how you embraced implementation science and what brought you to explore that in addition to your clinical discipline of being a doctor?
Okay. It's a long story, but I'll try and shorten it. So as I was doing my specialization, I think anyone who's worked in African health environments, I think, will attest to some of the many challenges that we face as we're treating our patients. There's a lot that is not tailored for our setting. In many cases, some of the guidelines that we use are, not tailored for the African setting, and there's always having to adapt those guidelines to our setting for that to work. And as I progressed through and I was introduced to TaskPen and introduced to implementation science, I felt that it's implementation science is one of the ways in which we can answer a lot of our questions here in Africa and solve a lot of our public health problems that are happening here in Africa. I like the way that the frameworks are built to be contextualized to the setting. I think that's very key. And I think that's what might speak even to sustainability of whatever changes that we want to take. So basically just the drive and the recognition that there's so many issues that we need to take care of, that we need to solve in our setting, I think is what drove me to, to be passionate about implementation science. Mm-hmm.
Well, thank you. And I know you're also you extend yourself in capacity building for the next generation of folks, and as a mentor, do you have any serious or humorous anecdotes that you could share with us about the joy and or challenge to being someone's mentor?
Wow. Well, the challenges of being someone's mentor is basically trying to, I think it's challenging to really know where your mentee's head is at. And I think maybe one of the ways I would approach that is, for mentors, is to really understand who your mentee is and know what they are passionate about. I think then you have more success with them. Um, yeah, so that's from a mentor's point of view. And then just being generous with knowledge, generous with experience, I think is also very key for any mentor. Yeah, I hope that answers your question, Rebecca.
That's a great insight about knowing where your mentee is. I hadn't thought about but that's key. That's like on the ground with the research question. That
Yeah.
was lovely. So thank you. Um, what has surprised you about this study? Good or bad? What are
Oh,
some of the things you scratched your head?
yeah, so I was listening to Cara and John, and there was a point where they were talking about anticipating some things. And what I have learned with taspin is you cannot anticipate everything. Trust me, something will surprise you. So we had several surprises at taspin. Before my time, they had COVID. COVID came in. Then after that, in Zambia, we had in Africa, we have public health crises that can occur. In Zambia, we had a major cholera outbreak. Um, Patients didn't want to come to the facility anymore because there were most of these places were turned into treatment centers, and so that was a challenge. And then, of course, we had climate change. Unfortunately, we had a drought in Zambia the whole of, I think, last year and the other year, and that really impacted a lot of the power generation because we depend on hydroelectric power. And so you can imagine there was massive blackouts in the country, massive power cuts, and you need, as a study, you need smart care to work, right? You need the hardware to work, and there's no power. You can't enter the data, and you have to now start thinking around, strategies on how to mitigate that. And we had to come up with some really creative ideas, some creative thinking, solar powered, chargers, solar backup solutions. We had to fork out quite a bit of money for that and just to set it up and running. So yeah, there's quite a lot that would surprise you. The other thing I think that surprised me is, when John was talking about how in the community you find people don't want to come to the hospital. You'd be surprised that even those that come to the hospital don't want to take treatment. So now that becomes a challenge because how do you retain them into care? And so you have to develop a sort of mechanism of how you will engage your patients better, how you improve the counseling. That becomes a gap in the health system that you know that you need to fill. And that's one of the other things that challenged me, where we had to really think about how to engage the patients better through the cascade of care so that they could be, more knowledgeable about their condition and more understanding that they need the treatment. So, yeah, those are some of the things I would mention that surprised me.
Well, thank you. Um, so as you described so beautifully, you and your team and the group have risen to some really challenging events, and you have wonderful ideas. Do you have any music or just personal inspiration that keeps you going sometimes when some of these things occur? We started off with they were playing music before we started today, and of course Nigeria is well known for Fela, and Africa has great music. You don't have to name an
Yeah,
African music,
yeah.
but is there's
Mhm.
something that gets your blood pumping in a good way to keep up and go? Because I imagine it's kind of difficult at times.
Oh, okay. Well, on a light note, I do enjoy our Zambian music quite a lot. So
Oh,
that
good.
that gets me going because it's a lot of storytelling in very funny ways. And you can laugh, you can dance to it, you can even cry to it. So that just gets your mind off things. Yeah, it gets my mind off things. And then in terms of something that would inspire me to keep going. I think one of the one of the documentaries that I once watched on Netflix called Live to Lead by I think the Royals, I think they're now in America. Um, I think really, really inspired me how I saw how people rose to through certain challenges all over the world and they were able to overcome and become great people that we respect today. So I think that was very inspiring and say, wow, that person was just like me and I can do it. So that inspires me. Yeah.
That's lovely. I'll have to watch that. I will say, while you were talking about the holistic approach to fostering sustainability as TASPN has gone along consistently, I thought about a phrase about leadership. So leadership is really providing a means and support for people to do better when you're not there. And I think that's
Mhm.
exactly what TaskPen has done in fostering this well integrated approach, but also so that this, as shown to be successful, can go on in a sustainable fashion. So I salute you and your colleagues for all that you do. And I have no more questions, but we have a large group of people out there with wonderful thoughts. And as you see, we have a great discussant. Are there some more questions that you could put in the Q&A?
Thank you so much, Rebecca. Thank you. And thank you, Dr. Anchindika. Thank you, everyone. So please, if you have any questions,
Yeah, thanks for having
kindly
me.
put them in the chat so that we can answer everything together. It's easier that way. So please put your questions in the chat. While folks are thinking of any other questions, we have just 10 more minutes remaining. So we'll start putting up announcements and then we can take any other question that comes along. But to summarize today, I think we heard from two excellent speakers. We heard from Dr. Cara Lewis from NHLBI, and we also heard from Dr. Anchindika from Zambia. Thank you so much, and thank you, Dr. Rebecca, for co-facilitating these sessions. Thank you, Udwak, for co-facilitating these sessions. Thank you for Ivan and Nisa for bringing this to everyone. We deeply appreciate it. For everyone, please note the sessions continue tomorrow. We have a panel of experts that will be talking about mental health and mind and body. We have Gregory Aarons, we have Vidya Vedam, we have some other colleagues that will be speaking. So please, it's a date, do not miss it. Dr. Onyeka, Professor Onyeka, are there other announcements that we want to put up now while people?
Yeah, okay. Yeah, you
Yes,
can.
go ahead, please.
Yeah, you can talk about the conference and tracks.
Yes, so like you all know, the Nigeria Implementation Science Alliance, we hold our annual conference every year. This year is our 10th year anniversary, so we are looking forward to a spectacular conference come September, the second week of September. The abstracts deadline are coming up very fast. They are due on Friday this week. Stephen, can you please see if I can find the submission. Okay. So please submit your abstracts. The deadline is this Friday. We look forward to receiving your abstracts. So that's the link for submitting your abstracts. We look forward to everyone to seeing your abstracts. The deadline is this Friday, and the conference promises to be spectacular this year. Thank you, everybody. Any other announcements, Professor Onyeka? So this is the conference abstract call. If you have not seen it, we can also share it again to all the attendees from today. We look forward to getting your abstracts. Professor Onyeka, any other announcements?
None for now. But I
Do we
think
still
you
need
have
to
questions.
complete the poll? Did we complete the
Yes,
polls?
yes, please. Yes, please, if you have not, because we've repeatedly put the link out there. I will put it out again. And before you drop off, please complete these polls. The link will go on the chat again now.
Okay.
The poll allow us an opportunity for you to also guide in terms of topics that we bring in, and we focus on this during this our research week. Last couple of years, first time we have done theory and frameworks, and we are going to have as part of monthly webinars. There are many platforms for capacity building that we have, and all of those capacity building are all provided to you free from the Nigerian Implementation Science Alliance. One of them, of course, is the weekly research in progress. If you are developing any proposal to submit, whether it is your first time, whether it's your 10th time, and you're looking to get input from individuals who have also had grants and implemented projects in Africa to give you feedback, you please try to join that meeting. It's on invite. You have to submit what you're working on and you get invited to the group. It is a closed group because people's intellectual property are being discussed. So we don't want people to come in to listen. We want people who are actually working on a project to bring in their project and get feedback on those projects. Whatever you bring in, nobody else works on those projects. It's also a very good framework for you to find collaborators in Nigeria or in any other part of the African country that join us, that you can do that. So that's one platform that we have. The second platform is every Monday, the first Monday on the week, we do bring in specific topics, and that's where some of the things you complete help us to guide us on the topics that we bring in. In July, first week in July, Monday in July, we are going to be talking about theories, models, and framework and implementation science. Professor Onyeka, I don't know if that flyer is around. It would be nice to show that. But that's the second platform that we have. The third one is, of course, the Nisa Research Week that you have here, that we have biannually. The fourth one is the CITES Scholar Program. This is a 52 12 months didactic and mentoring approach that we have. It is selected from across the country. It is quite competitive, but each year we have a select of about 12 to 15 individuals. This year we had 168 applications for those positions. But if you get that, you actually get mentoring and didactic lecture for a whole year. The output is that will help you submit your first or your 10th grant. And then, of course, the NISA conference that Dr. Oloepe talked about. So take advantage of all of this capacity building platform. They are delivered to you free from courtesy of Nigerian Implementation Science Alliance and all the partners that support it. Nigerian Implementation Science Alliance is not an organization. It is an alliance. It's an alliance of multiple organizations. The Ivan Research Institute acts as the coordinating center for that alliance. But that alliance pulled together academic institutions, implementing partners, and government agencies to look at policy, research, and practice. So please plan to attend. It will be a very good thing for you. You will not regret that experience. Thank you for joining us.
Thank you, Prof. So before we leave, I wanted to thank the co-facilitator, also Uduak Akpan. Thank you so much for all that you do, and EQs for all your support. I was wondering, Kara, if you have any final words, Dr. Lewis, before we close, or Rebecca, if you have any final words before we close.
Can you hear me?
Yes, we can.
Yep.
Yeah, just big gratitude for the opportunity to join you today. We are really impressed with what you've stood up here, and incredible work was presented that you all are leading. And if we can help, please do reach out.
All right, thank you. Rebecca?
Fantastic. That's all I could say. Can't say any
Thank
more
you.
than that.
Thank you,
And
Rebecca.
thank you for your time, Anchi, because I know it's not convenient, but boy, it's inspirational.
Thank you, Rebecca. Anchi, any closing thoughts before we close?
Well, just thank you so much for having me and being able to share my story and what we are doing. I think it's pretty exciting work. Yeah, and just I hope our story has encouraged a lot of you guys who are doing similar work and facing similar challenges in our African context. Yeah.
Thank you, Anchi. Uduak, any closing thoughts?
Thank you very much to the panelists. We've learned a lot, or for me, actually, I've learned a lot. And thank you to the organizers. Dr. John, thank you for facilitating this session. Thank you very much. And thank you to the audience, actually.
Absolutely. Thank you to the audience. Today, I think we had over 100 people. I don't know how many exactly, but that was excellent. Thank you. In closing, we wanted to say thank you, everyone. We will see you tomorrow and the discussion will continue. Please log on time, 4 p.m. West African time, 11 a.m. Eastern time. Which other time zone again? 8 a.m. Pacific time, and all the other time zones, wherever you are logging in from. And we hope that tomorrow's session will be exciting, and we look forward to hearing from the panelists. Thank you, everybody, and have a good day ahead.
Thank you. Bye-bye.
Doc, when you get a chance, call me.
All right, for that answer.
Okay. All right.